And we're really excited to have you join us for the 10th program in the Kansas and Missouri Cancer Research Highlight Series, hosted by the Masonic Cancer Alliance and the University of Kansas Cancer Center. I'm Hope Crable, the Executive Director of the Masonic Cancer Alliance, and I want to first go through some housekeeping before we get started. I want to make sure that those who need continuing ed receive their continuing ed, and you have all the information you need before we begin this great programming. So, Tracy, next slide, please. So please put your full name and your organization name in the, for your name on the Zoom. So if it says Gloria's iPhone or Masonic Cancer Alliance, which is what mine said, I clicked on the participant tab and changed my name to Hope Crable. That's particularly important if you want to get continuing education. So if you're typing your name in the chat box will not document your attendance. It really does need to be on the participant roster. Next slide, please. So for conflict of interest, this is a continuing education programming. We have listed the conflicts. So Gary Doolittle, Kristen, Burkett, and Stephanie Sherode do not have any conflicts. And as the moderator, I do not either over the past 24 months, excuse me. Next slide, please. And to get continuing education credit, we do have physician credit available, nursing credit, social work credit as well, or you can get a certificate of attendance. You will be shown how you can get that credit, and you can see each of those are for 1 hour. Next slide, please. Today, the discussion will be around clinical research utilizing financial navigation to address cancer-related financial hardships and describe utilizing financial navigation to address cancer-related financial hardships. And finally, you'll be able to explain the overall impact of financial toxicity and what it plays in the lives of cancer patients and their caregivers. Next slide, please. To get the CEs that we talked about, you can either scan this QR code. You can go on to EADS at www.eads.com and put in the QR code. My personal favorite is to use my EADS mobile app, where I can just put in 84 DUCT, and that will automatically prepare me for getting CEs. And it's very nice to do this because at the end of the year, when you need to document your continuing education, it's all nicely laid in the EADS program. Next slide, please. So with that, my piece of housekeeping is over. It's really my pleasure to introduce Dr. Gary Doolittle, the Capital Federal Masonic Professor of Medical Oncology at the University of Kansas Cancer Center and the Medical Director of the Masonic Cancer Alliance. He is a friend of mine, and I'm sure of everyone on this Zoom call. Dr. Doolittle has been a faculty member in the Division of Clinical Oncology at KU for more than 30 years and has a subspecialty interest in the treatment of malignant melanoma. So on behalf of MCA and the KU Cancer Center, we appreciate you taking time out of your day to be here with us. Welcome, Dr. Doolittle, and thank you for moderating the program for us.
Thanks, Hope. It's great to be here this evening, and good evening to everyone. And as Hope said, I'm Gary Doolittle, and really excited to be able to moderate tonight's program. This is such an important issue for patients and their family members, so it's really appropriate, I think, that we highlight such a challenging problem. Again, on behalf of the MCA and the KU Cancer Center staff, just thanks so much for taking time out to be with us this evening. A few more housekeeping issues. This is a Zoom call that is recorded, so we just want you to be aware of that. If you have a question, please place it in the chat box. The chat box will be monitored continuously, and MCA staff members will actually be the ones posing the questions to our presenters. Please make sure if you do have questions that pertain to specific patients, that there is no patient information attached to the question, right? We want to respect privacy and be compliant with HIPAA. And with that, let's get started. Our first speaker this evening is Kristen Burkett. She is an advanced practice practitioner in medical oncology at the University of Kansas Cancer Center. She's been a nurse practitioner for 11 years now, and brings, I think, a unique perspective to this whole challenge of financial toxicity. And Kristen, with that, I'm going to turn it over to you.
Hey. All right. Hi, guys. Thanks for joining this evening. We're going to talk about financial toxicity for the cancer patient. Next slide, please. So I just thought it was kind of fun to add a picture in here. So as Dr. Doolittle said, I've been a nurse practitioner for, I wrote 11 years. 11 years. I've been with Dr. Doolittle for 10 years. But I've been at KU for most of my, as a registered nurse and a nurse practitioner. I wanted to show you here, I've got two sons. So my oldest is Will, age 10, and Austin, 7. And then this was recent at the postseason Royals game. So anyway, there's that. Next slide. I wanted to talk a little bit about my role as a nurse practitioner. We see, Dr. Doolittle and I see patients side by side in the outpatient clinic at Westwood. And of those patients that we're seeing, like for instance today, we see people prior to getting treatment. So whether that be immune therapy, chemotherapy, or oral agents. We also see patients for surveillance, skin checks, following CT scans. With that, there's a lot of emotional, social support we provide for our patients daily. Next slide. And talking about relationships with patients, frankly, this is, why I became a nurse practitioner. My relationships I can build with others and really feel like you're helping people is why I wanted to be in this role. We are routinely, outside of seeing them in clinic, we're routinely calling, checking in, MyChart messaging. So we really develop a really close bond with our patients. I think that really helps build confidence when they hear from us, often helps build confidence in our team. And they rely on us to communicate in a timely manner, assist them when they need help. Next slide. Collaboration is really important. We work very closely. I work very closely with Dr. Doolittle. If he's not in clinic with me, he hears from me every day. We refer often to subspecialties, often rheumatology, endocrinology. We work very closely with our social worker. Her name is Tanya, and we couldn't do our job if she wasn't there and available to us. And then also the financial team, which also helps us with Medicare, Medicaid, and then the medication assistant team through pharmacy. Next slide. So this brings us to the financial toxicity. Why we are all here. It's a term used to describe the negative impact of medical care on patients' well-being, health, and financial security. The big thing is that it impacts any patient regardless of their financial situation they're in. Whether they do very well financially, it's still going to impact them. It plays a major role in their quality of life and well-being and hardship. I was reading a recent article that said that about 30 to 50% of all cancer patients experience major financial burden early in the disease course. So, it's quite impactful. Next slide. I really like this diagram. It breaks down how the predisposing factors then play into the medical financial hardship and then the downstream effects of that. And so, if you just look at a couple of different things that are predisposing factors, advanced age, financial status going in, gender, race, and insurance, obviously. And then work is involved, debt, the psychological impact that has, and then how they cope. And so with that then goes into, if those are poor, then poor quality of life. It impacts the spouse, and then it increases a higher patient emergency room and hospital use. Next slide, please. So the this credit study, so it's SWOG S1912, is a study that we have here at KU. It's a randomized trial addressing cancer-related financial hardship through the delivery of a proactive financial navigation. So the primary objective of this is to, excuse me, just a second. To determine a proactive financial program for patients planning to receive cancer treatment, see if this decreases the risk of material financial hardship over 12 months with patients that are newly diagnosed or recurrent metastatic cancer. So next slide. So what we currently do within our practice is, if a patient reports financial burden, we have a team of financial counselors that we can refer them to. And oftentimes when they meet with the financial counselor, they'll talk with them about if they can get them set up with Medicaid or on disability. If we also have medication assistance that can help us with if patients can't afford drug or immune therapy. And then we also work very closely with our social worker, who can then kind of help us with everything else. She can help with cab vouchers, transportation assistance, copay cards, grants, applying for Medicare. They really are instrumental in what we do. We were just talking with our social worker, Tanya, today, actually in clinic, and she was just talking about how, sometimes getting a patient that needs to be on a stretcher, how getting them to clinic, that transportation can cost, sometimes, upwards of $1,000. And that's significant, and it's a big burden for patients. So next slide. So this talks about the credit study that I mentioned, the S1912. So the criteria, as I mentioned before, they must have a new diagnosis of metastatic or stage 4 cancer, and they must receive cancer therapy within 90 days of registration. This also includes the spouse or partner can also be eligible for this. So when a patient is consented and enrolled, then they are randomized to 2 groups. So group 1 is the control arm, and they have access to financial literacy videos. And then the group 2, the intervention arm, will have the videos as well as financial counseling. So next slide. And this is a breakdown of the video topics. I won't go into too much depth. You can see what the different topics are about, but I do, when I've looked through these, I do think that they could be really helpful, specifically with the cancer care costs. It talks about brand names of drugs versus generics, types of chemotherapy, clinical trials, and then even the part on decoding insurance, I feel like was really helpful. It talks about out-of-pocket costs, just different things that insurance covers, copay assistance. So these are the list of videos that they are given. Next slide. So the control arm, which is the group 1, so they have access to all of those videos. They're short videos. They actually did a good job of breaking down the minutes of these so they weren't so lengthy, hoping that people would take time, or, if you're only watching a video that's a couple minutes long, maybe more people will be more apt to watch. So there's not a requirement to the number of videos they have to watch, but they are told to watch ones that they find interesting, and then during their questionnaires they're asked which videos they watched. Next slide. And then the second group, they also get the videos, same scenario, but they also get a patient advocate foundation case manager that will then set up times to have meetings and counseling sessions with them based on their needs. Next slide. So I'm not going to read through all of the analysis with this, but as you can see, it's what they're basing these off of. So The financial hardship, if you look here, it's based on credit report, any new loans, exhausting credit, bankruptcy, or delinquency. So these are what is measured with the questionnaires. Quality assessment, financial assistance and navigation services, and then the community clinic assistance, if they had availability or lack thereof of financial assistance. The next questionnaire is regarding just financial worry. So it talks about how much worry and burdensome this is. Next slide. A questionnaire regarding quality of life and adherence if they're actually taking their medications, and then emergency stays or trips to the ER. Next slide. So the credit study accrual, nurse practitioners coming to become, or mid-level providers becoming PIs is new to KU. I became the PI for this study in December of 23. Our trial opened October 28th of 21. And so at that time, there were 5 consented and 3 that enrolled. So since then, or maybe in addition to, we've enrolled 16 participants. So 14 patients and 2 caregivers. So we're excited about that. It's a trial that hasn't accrued very well nationally. So this is something, again, we're excited about. I think that one of the reasons that it's important for nurse practitioners to join and become principal investigators is because we are able to spend time with patients. We get more a lot of time, oftentimes, than the physicians do. A lot of times we're seeing them weekly because we have more time than physicians do, due to how many patients they're seeing. So we can really develop their trust, and we get to know them well. And I think that this does impact, whether or not they join a clinical trial or not. I also think when you get someone else involved as a PI, there's new excitement with the trial. So I think that helps with participant enrollment as well. Next slide. So barriers to enrollment. Initially, there was a lot of reluctance with this. The patients and their caregivers are really reluctant to give out their social security number, as they should. How often do you get a phone call that's a spam call asking for your social security number, and getting these left and right and spam, and people are just very reluctant to do that, which I understand. Some feel that the study won't benefit them based on their current economic status, which is untrue. And then the lack of familiarity within the study team, I think, also is a barrier. I think sometimes there can be trial fatigue. KU does a good job of offering clinical trials. Because of that, I think therapeutic trials often take precedence over non-therapeutic trials. Next slide. So ways to improve enrollment. We work really closely with our study coordinator, Rachel, and she deserves a lot of credit here because she does a fantastic job of supporting our team and really is instrumental in getting these people enrolled. So I think having a close relationship with your study coordinator is very important, obviously. Dr. Doolittle and I actually had a conversation today just about how when you approach the patients with clinical trials is very important. With this study in particular, I think not approaching them at first visit is important. So you don't want to first meet somebody and say, you've got metastatic cancer. We're going to start you on treatment next week. Oh, and can we get your social security number? Blah, blah, blah. So with this one in particular, we've got a 90-day window for enrollment. So we find it's important to maybe meet them a couple of times, get to know them better before we approach them with this. And I think that it's also important that patients know that we're not approaching them with our perception that they have a financial need. I think also it's important that the clinic providers are aware of the trial and are excited about the trial as well. We also need to make sure our patients are aware that the credit report, when that's run, it's a soft run, so it is confidential. Next slide. How can we improve? So with financial toxicity in general, I think there's a lot of ways that we can make improvements. I think that within the medical team, we can do a better job of being aware of financial toxicity and maybe trying to clump visits together so patients aren't coming into the clinic twice a week. You know, we can be maybe more open to talk with patients about how the medical care impacts their finances, and also know that it impacts the whole family. We used to do this, and we've shied away from it a little bit, but having patients meet with the financial advisors with the start of therapy could be helpful. Again, we work really closely with our social worker. She's in and out of our clinic every day, and she, just really thinks outside of the box and comes up with different things that could help people with their financial hardships that maybe we haven't thought of. I also think with telemedicine, we're using more telemedicine. I think if we have a lot of patients that drive 2 and 3 hours to clinic. If we're able to use telemedicine when possible, and then patients aren't, spending money on, gas and lodging for that. And next slide is for questions. Now I put this picture on just for you, Dr. Doolittle, because I thought you'd appreciate it. But it's just another one of my family. We're a big sporting family, and we're big K-State fans, so go K-State.
Thanks, Kristen. For those that are on the call, I have seen these slides before, and it took every ounce of self-control that I have to keep from substituting a Jayhawk in here. But there, are there any questions for anything from members of the call?
So I don't see anything in the chat yet, Dr. Doolittle, but I would encourage people to either raise their hand or put it in the chat. Kristen, I have a couple of questions for you as we wait for others to respond. I thought this was very interesting presentation. I noticed on our call, we have cancer center directors, social workers, oncologists, patient research advocates, nurses, as well as other community members. And one of the things that I wondered about is, first, could you say what SWOG is? Because you said it was a study for SWOG, and I want to make sure everyone knows what that is and how this study was opened at KU. So if you don't mind sharing that.
Yeah, and Dr. Doolittle, I was looking with the dates of, does that sound right? October of.
I think to just step in just quickly, Hope, it's Southwest Oncology Group.
Yes.
And it's a national group that conducts clinical trials, and some are interventional. And this was about financial toxicity.
Yeah, thank you. Yeah, I just wanted to make sure that was, and we don't even use the term Southwest Oncology Group anymore. It's completely SWOG at this point, right? So it's one of the ways that academic medical centers and community cancer centers have access to clinical trials. My question for you was really around patient interest and acceptability. When you talked a bit about the Social Security number, and I think we all are particularly challenged by that. And I know melanoma therapy can be particularly expensive. So as you, beyond just the concerns of sharing their Social Security number, are patients concerned about the time commitment or any other things related to the study?
That's a good question. We don't hear much about time commitment. We really try to do like the questionnaires and things that they can do while they're actually getting their treatment. And so that cuts down on time they have to do like outside of clinic hours. But no, that's a good question, but that's not typically something patients mention.
Very interesting. And I think it's very interesting just the way that the study allows you to connect patients to other resources within your cancer center, as well as provide some guidances too. Are there any other questions among the attendees?
Just going to ask, how long is the study open?
Well, when they enroll, they're on it for a year. It's the question, how long is it the actual study open for?
That you'll be enrolling.
Yeah, Dr. Doolittle, do you know that? I'm not familiar with that.
You get an update at SWOG, and it's actually getting close to closure. So Andrea just sent us, yeah, it's closed. It just now recently closed. I think one of the things that I would point out that Kristen won't is that there was a physician PI for this trial, and it did not accrue well. And so I'm going to ask you this, and okay, so let's be more clear. I was the physician PI, and it did not accrue well. And we were, as an institution, really looking at the nurse practitioner role in clinical trials and really encouraging nurse practitioners to take on the role of PI for a study. Do you have a sense of, between you and Rachel, what was the difference? And because I wasn't getting the job done, and Rachel's the same person. Rachel's excellent. She's Rachel Stickler is our clinical trials coordinator. What was the difference? What do you think the nurse practitioner role brought that was unique and patients responded so well to?
Yeah, and that's a good question. I will say our clinical trials coordinator, Rachel, she's just really fantastic. So I give her a lot of credit for this. I think maybe just a new set of eyes looking at it and a new interest in it and a new maybe excitement about it. I don't know, bringing in someone new, I feel like new people talking about it. And I would guess that that's probably more it. It engaged me more too, I will say.
You're more generous than I am. I think the role of nurse practitioners is unique from the physician role. I mean, I recognize we're both practice together, and our patients develop really strong bonds with the advanced practice practitioners in general. And I really do wonder if that isn't some of it, if there isn't this relationship and trust. Because I think you made such a good point. Like the first visit's a tough time to start talking about money, right? We know patients need to be informed. It's a tough time to start talking about it. And then you want to put a clinical trial on it that's also money. You got to have a lot of trust in the individual that's asking you. So that's Gary's view of it. I think some of it really has to do with the very strong, unique role you play with patients. So.
Thank you. Appreciate that.
I would also say, I believe that University of Kansas is one of the highest enrollers for this study. And it looks like it's still open for a little bit, but close to closing for enrollment. But that's my understanding, is that you all are doing a very nice job of enrollment. And I think figuring out some of those, when to offer a trial is important. I think Pivot has helped us think about it, and the patient research advocates are always really great about guiding us and thinking about how does research impact the patient journey, and what are the ways we can make it more patient-centered. And the timing of when you offer that study definitely is more patient-centered.
Are there any other questions for Kristen?
Does not look like it in the chat. Anybody on? Oh, there is. Andrea
it
Watson,
looks like
hand up.
Sorry, and Tony Sung also has his hand raised as well.
Yep.
Hey, Kristen, great work. I was wondering, do you have any information on what percentage of patients, or how many patients were approached out of the total number of, metastatics or heme malignancy patients? And of those, what percentage consented or declined?
Yeah, that's a really good question. I do have it written down. Is that something that I could get back to you on? Because I do have it written down. I'd have to rifle through all of my stuff, but I can email you if that's okay. Okay.
And if you have it, Kristen, while Stephanie's presenting, you could put it in the chat as well.
That's perfect. Thank you.
Okay, why don't we, let's go ahead and move ahead with our second panelist. Stephanie Sherode joined the Masonic Cancer Alliance about a year ago as the MCA's first financial navigation program manager. Stephanie is based in Salina and has worked as a social worker with the Tammy Walker Cancer Center, one of our MCA partners. She's really worked hard to build a program to serve patients from some MCA member site cancer centers directly, and to also provide technical assistance for those that are on the ground at our member sites. We're really grateful to the Kansas Masonic Foundation for their generous support of the financial navigation position. And Stephanie, we really appreciate your presence this evening and look forward to your talk. Welcome.
Oh, hello, everybody. And I just wanted to note, I did see another hand up there. I don't know if somebody had a question. It was Daniela.
Daniela,
Yes, I did not have a question. I just wanted to say something, if I may, but I can do it at the end.
feel free to jump in now, Daniela. And
Okay.
Daniela is a patient research advocate with Pivot.
So, I went with my husband for second opinion probably 7 years ago now, when he was treated at KU. So we went to MD Anderson for the second opinion. And so we only had one visit. And I remember how we had one person after another coming in the room. We were first time over there. We were overwhelmed with everything it was done, said, being through. And we did have at that appointment one person that wanted to enroll him in a clinical trial. And of course he said no. And why? Just because all we talked before, the financial burden. Although he was still working with both work, he had 2 insurances, and he was very financially responsible. He was stage 4, and he was told if so when we went for second opinion, he was in the middle of treatments, which means he already had R-CHOP. So he had lymphoma, non-Hodgkin's lymphoma. He was treated with R-CHOP as his first line of treatment, and he failed it. So, but at that time, we did not know when we went for second opinion. So he had some testing done, but we did not have results. Find out when we came back that his lymphoma was advancing his nervous system. But at that time, MD Anderson said, if the cancer is back, not to do any treatment at KU, come back to MD Anderson and he will be enrolled in the clinical trial. And what was he thinking? Financial burden. So thank you very much for thinking of this. And I'm sure we were not the only one. We were actually in a very good position, having 2 insurances. And he was 50 years old, working, but a lot of patients are Medicare. And as far as I'm concerned, Medicare is not free. So it's a lot of burden on people that work, on family that are left over. And I'm not telling you how I received KU bills for 6 years for a couple of $100 that were left. They were not in my name. It was not my responsibility. And until I called patient advocate and I said I had it for the past 6 years, I threw away these bills. But right now I think I'm sick of it. And until then, I receive monthly bills. So it is, yes, indeed, a lot of burden, even after the person is gone. So thank you for working on this and being considerate.
And thank you, Daniela, for your willingness to share your story. And I think that that's also just an additional sadness that comes when you get that bill after you've lost your husband. I'm very sorry about
Yes,
that.
it was a monthly, remember, for 6
Yeah.
years. Like
Yeah,
I
I'm very sorry to hear
like
that.
I could forget. I think those bills come from someplace in St. Louis. It's an automatic thing, but I
Yeah.
did not have the strength to call anybody, emailing anybody until this year. So it
Yeah.
took a lot of strength. And let me tell you, to tell you all this now, it takes me a lot of strength, even if they are almost 6 years. And I'm a nurse myself, and I could
Yeah.
deal with a lot. But most of these people don't have a nurse as a caregiver, are not in the medical field, and it's very complicated.
And thank you. And I think that's one thing that is always helpful for us to think about as we're developing financial navigation processes, as well as we study how to do that well, to really think about not just the burden on the family during the treatment, but also after the treatment. And so I appreciate you sharing that information. And I think, our goal with this study is to really find ways that work, and I think that you really put your finger on it. It's challenging if people have to travel for the clinical trial. So even if the clinical trial's expenses are paid for, if there's extra visits, whether it's coming to KU or a different location, and Kristen, you mentioned that as well, the extra burden of just extra visits too are a financial burden. So with that, Stephanie, I think I hand it over to you. Thank you, Danielle.
No problem.
So my name's Stephanie. I previously worked at Tammy Walker Cancer Center in Salina. I also had a history working with skilled nursing, so had some insurance experience from admitting patients to skilled nursing as well. In my role at Tammy Walker, I worked directly with patients. We did intake assessments, just follow up on distress tools that patients had completed, and of course, helping them find resources that were barriers to their care. And I found that most often my time was spent with patients addressing financial concerns that they had, and also that insurance literacy for both people who had insurance through their employer or government insurance was very profound. There was a lack of insurance literacy. So I kind of dug in myself and did a lot of learning on my own and educated myself on a lot of the issues that patients were presenting to me. Next slide. So in some of this, I'm reiterating what Kristen talked about, financial toxicity, just an overview of that evidence-based research shows that the cost of cancer can negatively impact cancer care and quality of life. And I was a witness to this over and over again, both in my professional role and in my personal life with family member that had to go through cancer treatment. And you're right, Daniela, it's exhausting. It's time consuming to try to navigate insurance, and then adding the complication of being ill on top of that. Most patients who are going through cancer treatment, they don't have the time, the physical strength, or the emotional and mental capacity to navigate. So Masonic Cancer Alliance is trying to help with that. Next slide. So financial toxicity can lead to patients skipping, delaying, or foregoing treatment. There is evidence that shows that there's increase in depression and anxiety, suicide, and overall cancer mortality rates. So it not only impacts emotional health, but also the cancer care itself. And cancer survivors file for bankruptcy at 2.5 times the rate of the general population. I also wanted to share some information. I just recently, after I did all these slides, attended a webinar where Triage Cancer, which is a national nonprofit that provides free education to not representation, but education on legal and practical issues for patients and their caregivers. They do have, one of their programs is called a patient assistance program, and it's for people to reach out and get some guidance on those related topics, legal topics and practical topics. Sometimes it's disability. And they shared that in 2023, the three top topics of concern, number one was health insurance, number two was disability insurance, and number three was financial assistance. Next slide. So what is financial navigation? Financial navigation is a proactive approach to treating financial toxicity by incorporating knowledge of the disease state and treatment plan with insurance optimization, and we'll talk a little bit more about that, and utilization of external assistance programs. I was fortunate enough to receive financial navigation training from Dan Sherman when I first started at MCA. And Dan has been a financial navigator for some time in Grand Rapids, Michigan. And he developed a model of financial navigation that has been successful, not only in decreasing toxicity for patients, but also increasing revenue for the cancer centers. And that a lot of that is through the insurance optimization. The focus is on optimizing insurance first. For example, enrolling a patient who may have Medicare but not know that they're eligible for a Medicare savings plan that could pay their Part B premium for them and cover all co-insurance costs. So that's just an example of optimizing insurance, and then finding resources for the remaining out-of-pocket costs. Next slide. And so what is the difference of what are we doing, what are most clinics and hospitals utilizing now versus the financial navigation model? So the financial navigation model is proactive. We evaluate the patients, meet with the patients to see what their financial needs, and using multiple tools to do this. And then the counseling is often reactive. You generally see, and they do a fantastic job, clinics and financial counselors that work at the clinics and the hospitals, meeting with those patients who don't have any insurance, who may qualify for Medicaid, or who are referred by the clinicians. And often those are kind of the term that we use are the low-hanging fruit, ones that we know are going to need assistance. But being proactive, there's oftentimes those patients that may not present as having a need or not approach anyone for help that could really benefit from assistance. And then the optimizing of the insurance is key. And then typically now, often those who have coverage aren't triaged to a financial counselor. And then in navigation, you can benefit both patients and the cancer center. So not only acquiring insurance and resources for patients, but also in that acquiring insurance for the patients, the cancer centers are getting reimbursement rates instead of writing off patient assistance for patient assistance. And in the counseling, the benefits to cancer centers can be more limited. Next slide. So where are we heading? And that's specific to Masonic Cancer Alliance and what we're trying to establish with the program. Currently, we're developing a remote navigation program. We have a couple of our member sites who are assisting right now. We're getting ready to start in Coffeyville, and we're assisting each of those two sites a little bit differently. The site in Coffeyville, I'm going to be offering direct help to the patients. And in Topeka, I'm going to be more of a consultant to somebody else that's been hired to do some insurance optimization and resource seeking for their patients. So we're really excited about both of those. I started last November, and it's kind of taken most of the year to meet with all of our member sites and see what their needs were and to get some programs up and running. So we're really excited to get those started in the next month. Well, one I've already started with Topeka, and the one in Coffeyville should be starting next month. Also identifying areas of, oh, I forgot to mention, which is huge, our weekly financial navigation calls. These are calls that we offer weekly for social workers, financial counselors, anyone who works with patients and their financial resources is welcome to join. And they're mainly to support those sites who don't have navigators, and who often those care coordinators or social workers are getting those referrals for patients that have financial needs. And so we meet as a team, we support each other and teach each other to help find those resources that patients need. And then we're also identifying areas of partnership across state agencies. I'm a member of KCP, Kansas Cancer Partnership, and I'm on several work groups with them to ensure that Kansas meets our goals identified on the Kansas Cancer Plan. And I'm also, whoops, I advanced when I wasn't supposed to. I also am working with Kansas Health Institute on a couple of different work groups that they have. One of them is Aging Friendly in Kansas, and the other one is Exploring Medicaid in Kansas. And just so that I'm advocating for those populations that we see are highly identified with needs. Next slide. Is there one more slide? Oh, you did it. Okay. Also, we are working with a researcher. I'm working with a researcher, Dinesh Paul. I don't want to mispronounce his name. Dinesh Paul Mudarankathan, I think is how to pronounce it. And he's a researcher at KU Cancer Center. And he's developing an app. It's called OncoNet. One of the research goals is to capture the benefit of financial navigation by connecting identified patients. There's a financial distress assessment that's completed, and connecting them with a navigator that will be me, or identifying resources on the app if they don't want to connect with a navigator based on their answers to those questions in the assessment. That resources would be identified and given to them to reach out to in the app. It's still in the beginning phases, but I believe he hopes to launch that before the end of the year, and we're really excited about that. And also for me, another place where I'm continuing to head is just in my learning. I have a lot of experience, but there's a lot to learn. And you're right. I was listening to Daniela. It's overwhelming. And it's overwhelming for somebody that works with the information on a regular basis. And, so I just am trying to continue to learn. I've recently completed SHIP training, which is Senior Health Insurance Counseling for Kansans, and that's specific training to Medicare and Medicare enrollment. I have received Medicaid training from KDHE, and I completed the patient navigator certification through ACS recently as well. So I'm just trying to continue to build my knowledge so that I can help others as well. So any questions?
Hope, Tracy, do you have any questions?
Yes,
for me?
we do have a couple of questions, Dr. Doolittle. Thank you. And Stephanie, thank you for sharing the information about the program. Maybe if those are the last slides, we can go ahead and take the slides down so that we can all see each other. So the first question we received was really about when you're talking to patients about finances, how specific are you about the cost of these expensive drugs?
It depends on the situation. It really depends on the relationship that I have with the patient and how much I gauge they're willing to share with me. So that's a hard question to answer, but that's really what it is dependent on, is the read in the room really is how open they are, and just learning to develop that relationship first, and then the trust builds and they're willing to share really a lot of information if they trust you.
Do you think that influences the patient's decision to move forward with treatment, the financial costs?
Absolutely. Absolutely.
So how do you address that?
I think the same way. I think you develop a relationship with the patient and the trust, and you have to find out what their goals are, and then work as a team to try to meet those goals for the patient.
Thank you. That's I can imagine that opening the conversation, because their decisions around cost and treatment are going to be out there regardless if you begin discussing the cost of treatment, right? It allows you to have that conversation up front and really learn the goals and have a goals of care conversation.
Yeah.
Oh, go ahead.
I just really, a lot of open-ended questions, when I'm meeting with them is, tell me about what financial concerns you might have. I see that you have such and such for insurance. Do you know what that covers? Do you understand what your insurance covers? Those kinds of questions. And usually when you ask them that way, it brings out more conversation and more questions that they might have.
And Danielle said that she felt and finds that also sharing that their health comes first and that the figure out the financial piece, that's what you're there for, is helpful. So thanks for that comment, Danielle. Another question we have was, how does insurance optimization actually work? And what does that mean, insurance optimization?
So insurance optimization basically is helping the patient to get the best insurance that they qualify for. And how you do that is being proactive by knowing the patients coming in, what kind of insurance they have, how old are they, gleaning the information that you have prior to know if they may qualify for something else by age, if they're getting ready to turn 65, or they're going to be enrolling in Medicare within the next few months, and they're going to need treatment. Just to have that information when you're first meeting with the patient, to talk to them about what do they know about Medicare, and let me share some information with you. And historically, patients who have been going through cancer treatment have experienced this with original Medicare, or this with a Medicare Advantage plan, and then sharing, these are the people you can talk to if you have more questions about it. Or if they, just knowing if they have an employer plan, you're doing a benefits investigation prior to them coming to the clinic, somebody's doing that. And then knowing what the results of that are. So when you speak with the patient, and that may have a type of cancer that's stage 4, and knowing that they're coming in and they're employed. So knowing how to have that discussion, that insurance potentially might not be there to cover them. They may not be able to continue work for a long period of time, or they may have to leave work, and that there's potential that they may not be able to go back. So knowing that there's resources out there if that patient needs to continue that insurance on COBRA that could potentially pay the premiums for that insurance moving forward if they can't work. Or knowing, what market that they could then get a marketplace plan. That's insurance optimization, is looking forward, knowing what the potential outcome of treatment and diagnosis might be, and what insurance options there are for them that will help cover them throughout. I don't know.
So that sounds really complicated, and I think it goes to the next question. So you're able to do that. Is there a place for patients to look that information up?
There really are a lot of beneficial. Medicare has a ton of information. The Insurance Commission has a really good website that has a lot of good information about that. Triage Cancer is a wonderful site that has guides for employer-based insurance, government insurance, disabilities, Social Security, retirement. So yes, there is a lot of information out there. It's having that person to connect them to those resources really too. And then walking them through it a lot of times. A lot of times, like I said before, the patients just don't have the capacity because it's so much. Yeah.
See, I got overwhelmed just when you're talking about it, and I don't have to make decisions around my insurance right now. So I can imagine. Dr. Doolittle, we have one other question in the chat. And I'm happy to read it for you.
The app sounds very interesting. Will it become available for patients to use? Is it a study tool right now? Is it a tool that patients are going to have access to?
It is a study tool right now, and they're hoping that patients, will be able to use it in the near future.
Yeah, that's great to hear. I mean, I've been at this a long time, and I think the thing that we all have to remember, and we all experience, when you're diagnosed with cancer, you're not necessarily functioning at your best anyway. You're distracted. You've got a lot of things to worry about. You're worried about the finances, but the kinds of things you're doing are so important, because even trying to find out where to go for information, as so many of us, myself included, at diagnosis, are kind of paralyzed with everything that's coming their way. So I see this as a really positive trend, and really impressed with the work you're doing. And particularly, I mean, you're developing the knowledge base, but also building capacity at our sites so that we spread the word and we get that out there. I think that's critical. So I'm really proud of the work that you're doing. And I get to say it because I don't do any of it. I didn't do anything to make it happen. So well done. Are there any other questions for Stephanie? Anything else that we're coming on the hour. Hope you're on mute.
I'm sorry. We have one more question from Daniela, and this is probably your last question that you have time to take, since we're on the top.
Yes.
Go ahead.
So I can tell you another one of my experiences based on this navigation business, which I think in our case, I was the navigator. So I had to read and inform and make all these decisions, and I'm surprised how well we did. But my question would be, can one of these navigators get to be assigned? Like, I tell you the example, for instance. So the job that my husband had for the past 3 months of his life had a person that I got to give her the right to talk in my name with the insurance. So I signed a document because KU applied 6 times for his last treatment in December before he went to hospice. And insurances, both of them refused to pay. The worth was almost $30,000, which I could have cared less. But being myself in healthcare, I kind of felt bad having those insurances for KU not to be paid, because he was treated there and he was treated well. So I wanted to be paid. So his job had this person that said, if I will sign a document, they can talk with the insurance to have those paid. And I said, well, I think I can do it myself. I don't think it will be a problem. Well, it was a problem. They still didn't want to pay. Well, whatever that person told them, the next day the bills were paid. So bottom line is, if there is a person in this navigator program that could do something like that for people, I think that would expedite the pay, plus will get a lot of burden out of the family.
That's great.
That is a good point, and there is navigation to be done after the process starts, and the billing is a lot where a lot of the patients have questions and concerns too. And there is a lot of work to be done. There are health advocates, trained health advocates out there. I don't know about in your area that do help with that. I'm not sure about if KU offers someone in particular with that or not.
Yeah, typically, like just within the practice setting, we work with our social worker first, and if there are others to be pulled in, then she tends to take the lead on that. But it's still not what Danielle is saying, right? It's still not solving that piece of the problem. I mean, expanding that role would be, sounds like it would be very helpful. We are at the
That's very interesting, really taking on kind of.
Okay. I just would really like to thank
Go
our
ahead, Dr. Doolittle. I was just agreeing, that's interesting.
Okay, great. Really want to thank our presenters today for taking time with us and sharing their expertise, and a special thanks to all of you that participated with us this evening. We really appreciate that. Stay healthy, have a great evening, and we'll see you at the next session. All right.
Thank you.